to the second half of the, the third half of the ICB meeting today. We're going to move straight to item 18, which is People at the Heart of Decision Making in West Yorkshire. And this is a paper of two halves, and it really outlines some of the work that we've done in collaboration and between the ICB and Health Watch West Yorkshire. The first half really is Hannah Davies from West Yorkshire Health Watch, talking about the work that ICB commissioned over the last 2 years and some of the learning from it and some of their recommendations and findings. And then the second half is Paul Hemingway from our communications team at the ICB, outlining some of the next steps and the way forward. This has become quite a very important piece of work for us, and as you've heard from discussions earlier on, hearing people's voices, understanding how our patients and service users receive and expect to receive, and what they think of our health service is very, very important, more so going forward in the new look ICB. And what's really critical to note is that the government took the decision to dissolve Health Watch. So we are expecting them to be. We won't be commissioning any work. Their contract finishes at the end of March 2026, and we will be in a transition period with them. But we are really wanting to look at how we work collaboratively going forward, retaining that independent voice of our populations and our service users and our patients. So Hannah, if I can pass over to you for the first half.
Yeah, thanks, Nadra. As you mentioned, this is an update that's been scheduled for a while, and as you've already highlighted, it's an important paper and subsequent paper from Paul at such a time of change and turbulence to ensure that the citizens of West Yorkshire are heard in all levels of NHS planning and decision making, and the plans to ensure they will continue to be heard at West Yorkshire going forward, which Paul will talk to. The report details the work we've done together as 6 local health watch and working closely with West Yorkshire ICB involvement colleagues and other colleagues, West Yorkshire colleagues, to ensure people's voices have been up front and centre. Simple steps like meeting in community spaces like we are today in Bradford, pre-engagement sessions we've trialled, where you as board members were able to speak directly with citizens, the intelligence reports which we've produced, really highlighting what matters to citizens around those inequality-themed meetings that we've had over the past 18 months. The work we've done with the Partnership Board, the Quality Committee, the Transformation Committee. The report details the learning from that, and hopefully they will be taken forward into what's planned for future. This alongside all the work the ICB has led via its involvement framework, its commissioning of us to deliver West Yorkshire Voice, its commitment to listening to health and inclusion groups and much more. And all this has meant that West Yorkshire has been seen as an exemplar ICB in involving and listening to the voice of local people. For us as Local Health Watch, we've greatly valued the work and relationship with our working at a West Yorkshire level, which has been as respect for each other's roles, and as Local Health Watch being actively encouraged to speak truth to power to the West Yorkshire ICB, and we hope that we've done that in a strong and effective way. In terms of looking forward, the future of Health Watch, we hope, is not quite as bleak as you've outlined there, Nadra. The work at local place will continue, so despite the funding at a West Yorkshire level finishing, the work at Local Health Watch will continue. It takes legislation changes to abolish Local Health Watch, so that won't come into effect probably until spring 27 at the earliest, and if it is accepted, there's likely to be a transitional period till October 27. So I can very much say that the work of Local Health Watch is happening, business as usual for us in local places. Just on the On the legislation itself, there is a considerable challenge likely to be put into the legislation next year as it starts to go through across all local places across England. There's been incredible support for the work of Local Health Watch, and so we are there is a lot of noise that there will be challenge to the legislation to maybe not abolish Health Watch, but if Health Watch is abolished, then it is possible there may be permission for places to commission independent voice locally. So I think there's a strong message that independent voice for people to have a voice into health and care services will continue, which feels very positive. And from a Leeds perspective, I know lots of other local places, for example, across West Yorkshire, but Manchester, Norfolk, Humber, across England, there are conversations taking place in local places to retain that independent voice, which feels very important. In light of that, in the report, we give our reflections around the future plans from a West Yorkshire perspective about how to maintain people's voices into that. And I suppose I would just stress we are very committed to still being part of that, even though the contract might conclude at the end of March, although I think we managed to squeeze it to the end of June. We're still very committed because we will still be out there listening to the communities and hearing important voices. We have highlighted in the report a few areas of potential risk or further refinement that we're keen to work with ICB colleagues around, particularly going forward. There will as we understand it, there won't be a Health Watch rep on the board post-April, so we're keen to have discussions around how you bring independent voice into a board like the ICB board and the other committees as well. I think the paper that in 19B, and I've already referenced it, the reality is there will be less resource from an involvement team perspective at West Yorkshire, but also the Health Watch resource. So we have to be realistic about what is achievable here. And then I think the third risk particularly is around that voice of people experiencing inequalities being unheard, and we need to make sure that we mitigate all we can around that. But just to conclude, I think hopefully you've heard me stress, but we're fully committed to ensuring that people's voices are heard at all levels of decision making, and keen to work with West Yorkshire colleagues going forward.
Thank you very much, Hannah, and thank you for all the work that you've done with us and for us. So if we take the paper B, and then we'll open to questions after that. Thank you.
Thank you, Hannah, and thank you, Chair. So the first thing that I'd just like to start with is just to thank the team at Health Watch Leeds on behalf of Health Watch Yorkshire, West Yorkshire, for all the great work that they've done over the last 3 years since the inception of the ICB. I think it's really pivotal that actually the paper that supplements the paper that Health Watch have just talked through is that actually it's really important that we make sure that patients, members of the public and our local communities are fundamentally part of everything that we do as an ICB and a wider system. And regardless of legislation and regardless of restructures and organisational change, there is a firm commitment from all organisations, including the ICB in West Yorkshire, that remains. So that's absolutely not open for question today. There's a firm commitment there, and there will continue to be that firm commitment. So as Najra mentioned, the current Health Watch West Yorkshire contract is due to end on the 31st of March. And the paper 18B, what that includes is a number of recommendations and some proposals about how we build on the firm foundations that we've done and worked on as a system to make sure that at board level, committee level and across the organisation and wider system, we're making sure that patients and members of the public are firmly rooted at the heart of our decision making. So one of the things that we've built over the last 3 years and continue to build on is the Insight Library. So many members around the table may have heard about the Insight Library. There's still quite a bit of work that we need to do across the system to enhance that. But particularly over the last 6 months, we've had a lot more organisations from across the VCSE sector, NHS organisations, including providers, commissioners, local authorities, and other organisations, including Healthwatch, to really feed into that insight bank. And over the next 6 months, there's a big push and a big steer to make sure that actually that insight bank becomes much more of a tool that actually should be used by all organisations across the Health and Care Partnership across West Yorkshire. So in effect, the more that you put into the insight bank, the more that you get out of it. So actually, it's about making sure that we continue to raise awareness of that and ultimately make sure that we get organisations feeding in everything from whether it's consultation, whether it's an involvement exercise, whether it's even conversational level into that insight bank, so it's always up to date. As part of the proposals, one of the things that we are really keen to take forward is the development of an experience and involvement group. Now, that experience and involvement group would report directly into the proposed Quality and Safety and Experience Committee. But that group particularly would be made up of ICB Place, infrastructure at the moment, also our VCSE organisations, local health watchers, local authorities, and particularly West Yorkshire Voice representatives, because actually that's one of the big things that we need to make sure that we continue to take forward and build on moving forward. So that group would be an evolution of West Yorkshire Voice that would meet on a monthly basis to really robustly scrutinise and look really carefully at what members of the public and our local communities are telling us across West Yorkshire. But that would also give us the ability and opportunity to look at where the gaps in our experiences and our insight actually is. So at the moment, we do a lot of great work with Healthwatch, but actually by working together as a much closer system with the development of the place provider partnerships, we can ultimately make sure that looking at the insight bank and all the mechanisms and forums that exist. So, for example, I'm just picking on some at the moment, the People's Voices Partnership in Leeds. There's an equivalent, for example, in Wakefield as well, that meet on a regular basis and really scrutinise patient public voice and experience. And as part of the proposals moving forward and the proposed experience and involvement group would actually be making sure that we build on the best practice and the great work that is currently taking place within each of our places, so that we build and put all that resource together, so that actually we've got a wide range of views, demographics within that group. That group would then report into the Quality, Safety and Experience Committee, as well as the other proposed committees that are proposed to take place across West Yorkshire. So both at committee level, organisational level, and ultimately up to board, by the time that the experience and involvement work gets to board as part of the deep dive reports that we're proposing, it will have been under quite a lot of robust scrutiny and challenge, as well as support from each of the different perspectives and groups across West Yorkshire. Now, what I'd propose just to kind of finalise on before we open to questions is that from a board perspective, again, there's lots of great work that Healthwatch West Yorkshire and Healthwatch organisations have done already, and building on those firm foundations, one of the things that we're really keen on as part of the use of the Insight Bank is about making sure that the reports that come to board and the experience and members of the public and patients actually informs the board about the conversations and the activity and the work that's happening across West Yorkshire, but it also provides evidence of impact. So actually, as an ICB moving forward, it's very clear in the Darcy report, for example, in the ICB blueprint, that we've got to be bold, we've got to be brave, we've got to be dynamic and forward-thinking. So actually, the reports themselves, in very similar way to what Hannah's done over the last few years and Healthwatch organisations, is about absolutely not making things look pink and rosy. It's about making sure that the reality of the experiences of our patients, our members of the community and groups are shared up to the board with clear recommendations about what we need to do moving forward, and then from the board taking those actions away and recommendations, and then evolving what we do in the future. So I would say the paper 18B really focuses on this is where we've got to at the moment, but actually with greater work and more alignment with the development of place provider partnerships and the new proposed ICB, there's a lot that we can learn from what we've done and actually improve that into the future. Thank you.
Thank you very much, Paul and Hannah. I can open it out to any questions or comments at this point. Fatma.
So I'm going to open this with a caveat that I am unashamedly biased towards Healthwatch. As a patient public advocate who started her career as the chair of Healthwatch, this is something that I really passionately believe in. So my first reflection is that the rationale behind the evolution of Healthwatch was to simplify bureaucracy and to empower the patient to speak for themselves. I really think from the recommendations I've seen that we can really strengthen that. I think having a steering group and having a conduit to board only takes us so far. I really believe there is something really powerful about the ability to meet with leaders, to share your lived experience and to be able to influence the change. I remember meeting a really influential gentleman in a health and wellbeing board in Dewsbury, where when I shared my passion for making things better, he invited me to co-create the change, and look at where I ended up. And I just think that there is something about how we don't create more structures for people to engage with, but we remove them. And I think that the work we did with Healthwatch of having those sessions where people could sit with leaders and share their lived experience and speak truth to power is really important. It's actually fundamental to West Yorkshire, and I would really advise us keeping it. I think there is also something about the fact that we are missing an opportunity to develop a new style of leadership, which is patient leaders. So people who have had maybe not so great experiences being brought into our partner organisations, to our collaboratives, to our, the people that are delivering the services and actually helping making things better. And I think this only takes us so far, and actually we could really build on this to make it far more impactful than it should be already. But having said that, I do think that Healthwatch could be better in some areas. So I think the importance of diversity of perspective is really important. I think the importance of advocating structural barriers is really important too. And I think that in addition to this, we should really give some thought to how we create trusted spaces and trusted influences in our communities to rebuild the trust that we've seen erode in public services of late. So I apologise for I'm not sorry, I'm not apologising for my passion, but I really think there's an opportunity for us to do and build on what makes West Yorkshire great, which is making the patient at the centre and giving them a voice to the board rather than having to go through structures, in addition to what Paul's proposed.
Thank you, Fatma. Points really, really well made, and I know Paul and Hannah will take this forward and make sure that we make the most of the opportunities through this transition period. Thank you, Fatma. I have Mel and then Majid.
Thank you, Chair. I know in Wakefield we're very committed as well to making sure that our place provider partnerships continue to have that system-wide community voice. So that's something that came up in our recent development session on the 9th of December with both our development discussions that are happening across the system around patient public voice. And furthermore, the local authority in Wakefield and ourselves have committed to continuing to funding local Healthwatch Wakefield, and there's additional contracts around mental health insights that's underway in the next 12 months as well that Wakefield Healthwatch are undertaking. So we're very committed to this, and I think the message we've given locally has been really clear that we'll continue to work with Healthwatch until the changes are implemented really.
Thank you for that, Mel. Majid and then Jane and then Tim.
Yeah, thank you very much, Hannah, and thank you very much, Paul, for those reports. Just want to build on what Fatima said. Really, it's okay building structures for people to get involved, but that is very exclusionary. It's only certain people will be comfortable to enter those rooms and to speak. And I would sort of urge us to go a lot further and think about this in a strategic commissioner context. And how do we get the patients and public involved in business as usual? So whether that's working at that neighbourhood level, the place leadership, however that looks like, how do you make sure members of our community are around those tables? They have sort of feel that they've got equal access to power, resource, authority, etc. I think that's really, really important. Otherwise, what's going to happen, we're going to see a lot of familiar faces in the same places saying similar things. So I think I would urge is really, really to think about strategic commissioning, think about that commissioning cycle, start from neighbourhood, start from streets, working all the way across there. How do we really give people power, and how do we really listen to their voices to help us shape what we're here to deliver in their interest? So I think we're at a starting point, and I think there's a huge amount of more we should and need to do. Thank you.
Yeah, thanks. So I'm also really proud, actually, in terms of how West Yorkshire ICB has integrated through Healthwatch, but patient voice into our discussions. Accepting, though, we're moving into a new world, I'm just trying to think about how we ensure that as we move forward, we're clear in terms of with however we get the patient service user voice to the board in the future, our role as the ICB board, a strategic commissioner, in terms of responding to that versus what we expect the place provider partnerships, because I expect it will be slightly different. And I think just as any sector is going through the scale of change that we are doing, be sort of rehearsing for ourselves and testing ourselves in terms of our understanding of what we're expecting at different parts of the system and the kind of interventions or response, I think will just help make sure that we are doing what's expected of us in the new world to the benefit of the users across the organisation. Thanks.
Thank you, Jane. It's just so much for us to think about. It just shows what opportunities we have ahead of us. Thank you for that. Tim, and then AC.
Yeah, thank you for both the papers. Lots in there. I just wanted to bring, certainly Leeds Committee of the ICB discussed this, and I know Hannah's from Leeds and has said we're working. I think it's really important. Someone who's not Healthwatch gives a view about what we thought. So I think there's a couple of really important points. One is, everywhere I go, I hear everybody saying that they believe the importance of an independent voice. I'm just wondering how we can bring that collective small number of conversations together to make a more powerful conversation. And one of the discussions we had at the Leeds Committee was whether we should start to ask, particularly potentially through YCare, I'm very aware that Andy Burnham's come out and been quite outspoken about this, that we are very clear that that is what we want in the system. There is then a bit of, well, is that Healthwatch or is it something else that looks remarkably like Healthwatch? I think that, again, I think it's in the AAA report from Leeds, we're clear that why break what is working reasonably well already? And that is why the conversations are happening in Leeds between NHS partners and the local authority about what that future might look like. But I think there is a question about whether we are committed as an organisation working with our partners, particularly political partners, to make that case more strongly to government.
Okay, thank you, Tim. AC?
Thanks, Anna, and thanks, Paul, for that. I think very useful. I don't want to add anything. I think between Fatima, Majid, I think most of you have picked up, and Jane mentioned about the role of the strategic commissioner. So it all makes sense, and trying to think about what our role would be and how we connect with. So if we are contracting places to execute around a certain contract, deliver outcomes, I think it's the place's prerogative in terms of how you want to execute that principle of bringing patient voice at the central of the designing of it. But from a strategic commissioning perspective, the only suggestion I would like to make there in that paper as the sort of co-design is how do we link it with the business intelligence aspect of it? So effectively, we are gathering intelligence, and that is one of the intelligence sources around our service users. So irrespective of the mechanisms that places probably use to execute that, if we can find a mechanism to get back that to our BI hub, that's where our future sort of commissioning intentions and approaches might change, rather than us being responsible for that directly. So set out the principle, this is what we want, but we get the information through. So care, for example, care opinion is one source for providers, so you can rely on care opinion in terms of what the larger patient voices are saying for providers. But for IHOs in future, it will be useful to see how we connect that. So worth considering that in terms of how we want to loop into the BI infrastructure that we set up.
Another useful point, but I think what we're collectively saying is that we've got to remain curious about what our patients and service users and people who are not our patients and service users yet, what they want from our services and from ourselves. And I think at the moment there's an expectation that if you are part of our population, not working for the NHS or not part of the ICB, etc., or not part of any voluntary service organisation, you've got to be able to be pretty organised to be able to speak to us at the moment. You know? And it's about turning that notion around hard to reach communities, because we are the ones hard to reach, and we've got to work on the fact that we've got to make ourselves easier to reach. And then when we hear all these voices, we hear all these opinions, how do we synthesize them into some sort of action that's going to have the desired impact? So I'll just throw that out as well. Tim.
Thank you. I think just reflecting on some of the other bits of discussions and thought I've had before, I mean, I do have concerns about the loss of Health Watch from the system, and I'm not convinced it's the right thing. And I think that issue of how you give people confidence that they're going to be listened to and building trust is a really challenging one. First thing being that for most people out there, they don't see ICBs and hospital trusts and everything else, they just see the NHS. And people who are cynical come in with a starting position of you're all going to club together and defend your positions and you're not going to listen. So I think there's a real trust issue and challenge for us in how we address that. I think thinking about the different roles of the ICBs and local providers is an interesting one, because I think clearly from a point of view of the new role of the ICB, then it's clear that the patient voice we want to hear is to help shape future commissioning. But I think we shouldn't lose sight there are always two aspects of patient experiences involving patients in shaping services. But there's the core issue of when we're actually caring for people, are we listening to them in that moment? And I think that's often been at the, and I feel that very much around some of the debates around maternity at the moment. The message from maternity reviews is that people don't feel listened to in the process of being in labour, and what we're putting in place is structural solutions that are about involving people in planning services in the future, because it's much harder to address. So I guess part of the challenge for the ICB in the new structure then is how in our commissioning do we make sure that that's one of the things we're expecting trusts and providers to demonstrate they're doing differently. I think my other theory about this is I mean, obviously, there's always a risk of an overlap between patient experience and complaints, because generally people don't rush to have their say if they've had a good experience. It's generally they want to do it there. And that always immediately then I think risks a defensive response from any provider. You know, if we're seen to be listening to this patient's concern, are we then validating that something went wrong? I think the other danger is that this could just push people who are unhappy with experiences in more and more into kind of a political sphere of talking to counsellors, politicians and others whose motives, I say this as one myself, whose motives then may not always be to use that experience positively to shape better NHS services, shall we say. So those sort of reflections I'd have on where we are at the moment.
Thank you for those really important reflections, Tim. Rob, would you like to say some things?
Yeah, I think it's been a really good conversation, because it sort of expanded and clarified some of the issues that we face. So I think, firstly, yeah, thank you to Health Watch colleagues who's still here. You know, that we shouldn't act as if Health Watch doesn't exist. It still exists and will continue to do so until legislation changes, which will be for some time. And I'd like to thank them for raising to the challenge that we gave them when Don Berwick said to us when we first started all of this, you should always make sure you have the person in the room when you're making decisions about them. And what I said to Hannah and colleagues was that I want you to do that job and make sure that's always the case. And you can be as difficult as you like, as long as you feel heard. And I think you can see from the papers that they've done a pretty good job at it. If you look at the conversation that Tim sort of broached about, if you look at what's happening in other places around our commitment here, maybe there's something that we need to do and revisit some work that was done by the NHS Assembly about a compact with the public. They said, look, this is how we're going to be, this is how it's going to be in the future between us. Because at the moment, I guess the public and patients don't feel like equal partners, even though it's their lives and it's their money. And we need to equalise that a bit. So I know Fatima was heavily involved with the NHS Assembly coming up with a compact. That was published as part of the NHS 75 report that the Assembly did about recommendations for the future. So if as a system, not just as an ICB, we were going to say there's a compact with the public that we expect as we develop this new partnership, which talks to, you know, you'll be involved in your own care, you'll be treated with respect and dignity, you'll have your responsibilities too, like taking your medicine, turning up, that kind of thing. We can also talk about some of the commitments that we would have as an ICB, as a strategic commissioner. So alongside that commitment, I think if we then said the commissioning cycle, as Ian's just reminded me of, that kind of assessing need, designing solutions, assuring yourselves that they're making a difference. The public and patient voice in all of those is really important. So how are we getting the mechanisms right for each of those to hear people? And I think the third bit that would then point to, which is in Paul's paper, is when we talk about the Quality, Safety and Experience Committee, what we want that to be is a dynamic thing which has people on it. We could get, a patient director, a person to chair that who isn't a clinician, or it can be a clinically led one, or it could be co-chaired. James and I have been talking about this, but we want to have a significant number of public voices on that committee because they're looking at quality assurance and quality improvement, whether that's the design of future services or the assurance of current services, and they've got to have a mechanism to feed into that. They've got to be able to hear people from the system. So if we've got that combination of a commitment, clarity in our role, the right governance, then it comes back to culture and ways of working. And Paul set out some of the things that we can do there. And I think that defence of those structured listening events where we had to just shut up. I know Nadja would love me to shut up right now because she's thinking about time. We just have to shut up and listen to what people are saying about mental health and then do something about it, for example. I think there's been a strong plea to get some of that back into these proposals. So maybe that's what we need to do in this next iteration of how we're going to work. We've got the benefit of having Health Watch around for a bit, and we've got some good insight and wisdom about how we might do that. But I would say, Nadja, maybe get to work that up a bit more and come back and say this is how it's going to work.
Unsurprisingly, always agree with what Robert Webster says, but I am really keen that as part of the recommendations we're really clear that we keep mechanisms that enable any member of the public to speak directly to us and to share their lived experience. I think that is really important from a principal perspective.
I think that's a really important principle for us to accept going forward, and if we can build that into our future communications and working with our populations. Thank you for that, Fatima. At this point, thank you, Paul and Hannah, for your papers. And I think we've had a lot of reflection on what you've presented to us, and what, of course, we know of your work, Hannah, and Health Watch. We've also had a look at the proposed ways of working, and we've sort of recognized the opportunities that this poses, but we think there's a lot more work to be done to make it even more effective than it's presented at the moment. And yep, Health Watch is definitely going to be around for a while, and we are going to be in transition, so we'd really, really value working more closely with you through all this as well, Hannah, and if you could also let your teams behind you know that we really appreciate and value everything they've done and are doing. And we have considered, or we've heard of some of the risks going forward, and I think we have yet to mitigate against them. But perhaps if we relook at our proposals, bring them back, take them to different, fora, we can really have something that's going to be brilliant and that keeps patients and our population at the heart of everything that we do. So thank you both and everybody for their conversation and discussion here. Thanks very much. Right then, it takes me now to Bradford Health and Wellbeing Strategy. Therese, you're going to just present it, and it's something we have to receive and note.
Thank
and I
you,
first
Chair.
say it's a really beautifully crafted report here. Such an easy read. It's really to the point. Our people and our population just go all the way through it. So, you know, let those who worked on it
Thank
know
you.
that.
I'll bring that back to the team. We feel really passionate about it. I'll be really brief because I know we're struggling
And
a
we're
little
curious.
bit for time. But it builds really nicely on the conversation we've just had. So I'll just briefly talk about the what, the how, and the so what of this document. So the what really, or the why, was we spend too much money in Bradford and Craven. We spend more than we are allocated through health and care. Our outcomes aren't good. And if you look particularly, I think there's a particularly difficult to look at table on, I think it's page 231 of the pack. It's the one with all the red lines. So if you look at how our population stand against the England average in that whole life course, there's lots of red. It's page 8 of the document. There's lots of reds. There's a few where we are better than England. There's a few where we are similar to England. But on the whole, particularly through that children's piece and some of our long-term conditions, we fare really badly. And if you think that on top of that we are a place that spends more money than we are allocated, then that's a difficult message for us. The other thing that spurred us to do this piece of work, we started it about this time last year, was the fantastic opportunity we've got around the Airedale new build. So we've got money coming into our place, fantastic amounts of money to come into our place to build a new hospital, but what we want to make sure is that our new hospital meets the needs of our population in 15, 20 years ahead, rather than meeting the needs of our population now. So that's why we did this piece of work. We used two really important areas of information to do the work. One was population health data. So when I came into place, I sort of said to our population health, we've got a brilliant population health team in Bradford and Craven, but I sort of said, we've got the data, but what do we actually do with it? How do we see it? How do we actually use it to shape our decisions? So I want you to use our population health data in a way that enables us to do something differently with it. And then the other thing that we did use, as you can see in the document, is the work from our listen-in events. So we've been running for 3 years now, our listen-in events, very much hand in hand with our Health Watch colleagues and our voluntary sector, where we go out into our communities and talk to them, as Rob said, listen and not speak. What works for you, what doesn't work for you. We've done it by disease groups, we've done it by age groups, we've done it by differences in religion or where people have come from. So we've got really diverse views from our population. So we took all that information together, and that's what has helped us build this piece of work. Importantly to say, for our local authority colleagues, we work very closely with local authority as well. We've got a new district plan that's just been developed for Bradford, and this is the health chapter of our district plan, our healthcare and wellbeing strategy. So that's the sort of the what and the how. The two pieces that I want to draw your attention to really importantly, when we looked at our population health data in particular, there were 5 population cohorts that were actually accessing particularly acute care much more than the average, and those were our children, young people, our seriously mental ill, palliative care, frailty population, and our elderly population. And when you looked at the attendances they have at health places, whether that be general practice or whether that be in acutes, they were significantly higher than the average. And that's what we wanted to tackle immediately, because we know that that's what's driving our financial issues across our place. We are £70 million overspent, so we wanted to try and see if we could manage that. And then I said it was really important that we think about what was going to happen in the future for our Airedale new build. So if you look at our predicted profiles, and that's on page 6 of the document, we look at our population segments now, and then we look at our population segments in the future. So what we want the Airedale work to be around the new hospital is to think about how do we meet the needs of the population of the future rather than the population of today. But that's the population if we don't do anything. I always say when I look at this table on page 6, when you see the healthy population bar chart at the very right-hand side, what you see is if we do nothing in Bradford by 2040, the percentage of our healthy population will actually reduce. So actually, if we do nothing, we actually make our population more unhealthy. So that was really spurring us on to actually do things differently. So the document sets out the work that we've done, what our ambition is, and how we do something with that information. So in terms of the so what, with those 5 population cohorts that are currently driving our acute demand, We're very pleased that we are a neighbourhood pioneer. We've talked about that before at this board. So as we are setting up our neighbourhood pioneer work, I've asked them to look at those 5 population cohorts to say, what could you do now through your development of neighbourhood working to actually impact on our acute colleagues, because they are seeing a real problem in terms of the numbers of patients that are coming through their door from those population cohorts. And we know, I talk a lot about palliative care, that we know that if you look at our palliative care patients, they shouldn't be ending up in A&E, they shouldn't be ending up in hospitals, they should be managing to stay at home or in their preferred place to die, and that's absolutely not a hospital. So really pleased that we've done some good work on that, but there's more to do. And then the other piece of work that we're doing in Bradford is our acute collaboration. We've got 2 acute hospitals, we've got some duplication there, we've got some gaps there, we've got some issues around financial and clinical sustainability. So what I've asked them to do through that piece of work is to look at the 2040 outcome and say, what are you going to do now with our acute services to make sure that when we get to 2040, we haven't actually made our healthy population less healthy. So the document is here. Some of the things that I would really recommend, obviously the work we've done with Healthwatch, the work we've done with our Listen In and Citizens. What really helped us, and that's on page 10, is our personas. So when we were particularly talking to our population and some of our partners, by having these personas of people who we met when we went out and did our Listen In, so people who are living in our communities, we could talk about what the conditions they had now or how they live now, and actually through our impact, through the work that we did, what was going to be different for them or what wasn't going to be different for them. So the personas have really helped, and if you come to our office, which is just over there in Scorex, we've got this lifestyle personas that help us really think about the work that we do, and I would recommend that to people as well. So I suppose all I want to say is please read the document. We have a very short, we took it to our health and wellbeing, to our overview and scrutiny committee a month or so ago, and they're really pleased to see it. They asked us to do an easy read version, which we've done. And it's out and about, and I think it's a really useful document because it's, as you say, Chair, it's understandable. And as we go through the headwinds, as I said, that are approaching through ICB changes, organisational change, this is the document that we are holding true. We're really clear. We've got 3 strategic delivery groups, one around neighbourhood development, one around acute collaboration, and one around our corporate collaboration. This document forms the basis of all of that work. So this is how we want to work together as partners to deliver better healthcare, better population healthcare for our people. So a short introduction, but I do recommend it to you.
Thank you very much. And I do, if you haven't been able to read it, I really do recommend you read it. It's really brought to life through the scenarios and the individuals. You really feel you get to know them and their passions. Any questions? Fatma? And
Therese, I love it. I really, really like it. I like how accessible it is. I like how it links to our equity and fairness strategy. I like how it is really accessible and it just speaks to people in a way that resonates. I do have a question for you, which is, what is a warm handover? I was very intrigued by that terminology, but I think it's a really cool way of getting the system to talk to each other. I also love the concept of trusted conduits, and it really builds on the conversation that we've just had. And the bit I'm particularly interested in is the trade-off conversation and how we start to operationalise that. Going back to Rob's point about the compact, I think there's some really great learning in here, but yeah, absolutely loved it.
Well done there. Should I just take Richard and AC and then you can have the final say, Therese? Yeah. Richard.
Yes, thank you for this. I mean, the graphic that you point to on our page 231, I think for me the starkest one is actually the boldest one, which is the children in poverty. And I think that really is the reason so many of these others are red. I think we need to acknowledge that most of these things, despite the investment of the health service, it's the fight against poverty and the system inequalities and the social determinants of health that's working against the population of this area. And I think the more that we can call for inward investment into this city, into the areas around it, that's the thing that will actually drive some of these reds to greens and ambers. Yeah.
Thanks, Therese. Again, as colleagues have said, really good, easy to read, as Nadira was mentioning, strategy. And you did sort of refer so what at the end of this. So I think what might be useful to understand as we go in the next sort of 26-27 commissioning intents and contracts, how would you map 2 to 3 priorities on the backdrop of that strategy? And then specifically, I really like narratives. So if you look at those personas, I really loved to read those. So how would we change Liv and Farida's, for example, outcomes in 12 months and 36 months? So it will be useful to rehearse that, perhaps at the board development or a future opportunity. So Bradford strategy is one of them. So clearly we have other places as well. How does those intentions and contracts actually improve outcomes in a sort of 12-month to 36 months trajectory?
UAC. Therese, final comments?
Yeah, thank you for that feedback. It's work of many people, so I will take it back. They'll be delighted to give you their thanks. A warm handover is where you don't drop people, so you don't. Well, probably both. But when we go out and talk to our communities, they sort of say, have I forgotten? Have I been forgotten? Do people still know me? Do I need to go somewhere else? So it's a bit about people knowing that we still have them, even if they have a wait. That's what I think it is. Just in terms of the children and people, I think that's a really important point. We just appointed a new Director of Public Health in Bradford. I met him on Friday. He's come from Hartlepool. He's got a really good experience of working very closely with partners. He's read the strategy because I talked to him about it. He's particularly interested in children, and he's going to come and have a conversation with us about how we can get in and do more around our children in Bradford. And actually, we do have targets around how we deliver some of this. It happens through our collaboration board, which I'm pleased to say James and Jonathan sit on. We haven't been quite as fulsome, I suppose, as we would like to be around targets and then delivery, but we are being challenged well by James and Jonathan to do that, so that will carry on to be a work in progress. So thank you for that.
Thank you very much, Therese. Thank you. So we're on a bit of a theme here, aren't we? We're now going to go to the Community Collaborative Update, and Becca is going to present it, and your team.
So thanks very much. Should we do some very brief sort of introductions? So I'm Colin Lynch, I'm Chair of Lacala Health and Wellbeing, but today here with my Chair of the Community Collaborative hat on.
Hi, I'm Johnny Hammond. I'm the Deputy Chief Executive at Colindale Huddersfield Foundation Trust.
Hi, good afternoon everyone. James Cook, Head of Community Services with Bradford District Care Trust.
And obviously Becca is a core part of the team as well. So you've got the substantive paper. We're not going to go through that. Just want to bring it to life a little bit by focusing on the so what for the West Yorkshire system and importantly our patients and communities. And I hope also drawing out a couple of things. One is the real positive momentum we believe is building up within the collaborative and with partners. And secondly, the real significant opportunities we believe there are now for transformational change along the left shift. So, set up in 2021, clear shared purpose, tackling challenges together where that makes sense, maximising effective use of resources, and also improving outcomes and experience both for current and future patients. And I think it's worth saying at this stage that earlier this year, we deliberately updated our objectives fully to focus on transformational change, fully to align with the government's 3 big shifts, and that was done very deliberately. So, James, I hand over to you.
Hi there, just going to showcase a couple of good examples that we've achieved through the collaborative. So the first one is pertaining to the West Yorkshire Community Dental Services. So from the 1st of April this year, Bradford District Care Trust led a West Yorkshire business case that secured £2.5 million non-recurrent investment to support mobilisation and contract delivery. And we used some dental contract underspend for 24-25 to deliver a number of cases, treatment under general anaesthetic, which is 68 for paediatric patients, 11 for special care adults and 128 paediatric patients were seen for routine assessment. So we drove real change there. We think this is a strong start and shows what a collaboration at scale can unlock. And under the heading of Waiting Well initiatives, again, we did some targeted work looking at waits for children and young people and adults with speech and language therapy. And our colleagues in Calderdale partnered with Mabel, a digital platform, to deliver 327 assessments that were completed. 283 patients were discharged as well as part of this work as well. So some real improvements. And again, we recognise reducing long waits in communities a national priority, but something that we're committed as a collaboration to achieve together.
Yeah, thank you. So you remember back in January, NHS England issued the Standardising Community Health Services, so the core offer, and together with colleagues in the ICB, we commissioned sort of independent experts to do a stock take of our services right across the region. And by way of reminder, we did that to build a shared understanding of how we align with that core offer, where are there any variations, duplications, gaps, and to build up a better evidence base going forward to help enable a real left shift. So what do we produce? So a full baseline report, lots of service comparisons and opportunity analyses on each core component of the offer, detailed appendices with insights on service provision, service demand, workforce, access, capacity, delivery models, and emerging risks and opportunities. So a pretty rigorous, comprehensive piece of work which was really interrogated by specialists right across our membership. In terms of headlines from the findings, generally fairly reasonably good compliance in relation to adult community services for the core offer. My notes here say children's services more variable with common gaps including urgent care for children and reliance on acute sites for audiology and lymphedema. In my language, it ain't good enough, basically. Significant variation in service models, access capacity, and also in naming, counting and coding practices, which of course makes comparisons really quite difficult, and also impact assessments and assurance much harder to attain. We found real opportunities to standardise core elements of the community offer. In other words, levelling up to the highest common denominator. There are real opportunities here. And we also found that data quality and analytical capacity significantly vary in different places, and outcome measurement is very limited in certain places as well. So in short, we do think that this stock take really does help us give improved evidence and insight and a clearer platform for commissioning and service reform. And Johnny will take us through some forward-look examples.
Thank you, Colin. In terms of looking forward then, we'd suggest that by commissioning at scale, we'd be in a good position to support the West Yorkshire system with its priorities of neighbourhood health and healthy working lives. Also really keen to support the ICB priorities around prioritising returning to core operational standards, commissioning for integration at the neighbourhood level, improving responsiveness and capacity within urgent care pathways, and increasing and improving how we commission for prevention and early identification. What I'll do now is just take the board through a couple of work programmes and 4 priorities for the collaborative looking forward. So first, as a work programme, we have a real focus on discharge and the 2-day length of stay ambitions. So we have alignment across West Yorkshire with an ambition to start reablement or intermediate care within 48 hours of referral. So doing this will reduce delayed discharge, support with reducing occupancy pressures within hospital, and reduce the risk of deconditioning for patients. Using length of stay analysis to target variation and drive improvement will support that. Initial audit does show quite a significant variety in length of stay across reablement and community bed pathways. It's only on the Calderdale side that we are meeting the 2-day target currently. So there is clear scope to improve outcomes and efficiency. Then secondly, for the West Yorkshire Rehabilitation Model, the Community Collaborative is hosting currently a West Yorkshire ICS Rehabilitation Lead, who's leading work to expand long COVID provision for people with multi-comorbidities. So that's focusing on symptoms such as breathlessness, fatigue, speech, anxiety and depression, rather than condition-specific labels. The initial focus is vocational rehab, and we're linking this to the Healthy Lives pilot. So looking forward to the looking through the 25-26 work plan, so into next year, there's 4 priorities. So firstly, the West Yorkshire Core Standardised Community Offer. So the focus on delivering consistent, high-quality services that reduce variation and improve outcomes. Establish a standardised core model and embed proactive, integrated neighbourhood level care. Second priority being West Yorkshire system transformation and programmes, so growing mature place-based provider partnerships, strengthening the West Yorkshire strategic commissioning and planning, and delivering on neighbourhood integration and prevention priorities. The third priority, West Yorkshire-wide community service offers. So where it makes sense, deliver shared, standardised models where scale will help. So examples could include falls, rehabilitation and speech and language therapy. And then fourthly, community weights recovery. So reducing all age long waits, including over 52 weeks, to an agreed local trajectory, meeting national performance requirements, and including 78% within 18 weeks by 26-27. And I'll now hand back to Colin.
Brilliant, thanks very much. So things have moved on positively since the paper was submitted. Specifically the ask from the ICB for the Community Collaborative to advise West Yorkshire Places on community investment opportunities going forward and to collate some feedback from those discussions, I think, for mid-Jan. To that end, you've already kindly enacted 2 of the paper's recommendations in that light. I think first thing to say here is thank you for that, and thank you for listening, and I think appreciating the opportunities that there are here. Our membership definitely welcomes this direction and the opportunities that the community uplift actually brings, and they're very much up for it. I think that those discussions have already started. In fact, I know they have with place accountable officers, certainly with the mental health collaborative and integrated neighbourhood health colleagues, as well as to where West Yorkshire level and place level investment can have the best impact for our populations. And they're under various headings, like the certain productivity initiatives being discussed, for example, tackling long waits, transformation initiatives like the low-level falls prevention business case, and the 0 to 2 hour urgent community response offer for children and young people, which as we've seen is a very clear gap from the stock take. I'd also throw in there potential for contracting at scale, for example, West Yorkshire-wide service specs potentially on certain services, falls and speech and language therapy could be that. I'd also put in here the opportunities for standardising, counting and coding across all providers. That really would impact beneficially in relation to improving assurance around outcomes. I'm not going to go through all of the other recommendations in the report. You've got them there. I think just to conclude and say that we're ready to continue partnering at pace and to build on this momentum, to build on the really excellent trusted relationships and work in partnership based on an improved evidence base as well. So, Chair, that was a very quick rattle through, and up for any comments or questions that I'm reliably informed my colleagues will be able to answer.
Okay, thank you very much indeed, Becca and Colin and team. Really, really great to hear the work you've been doing and the real difference you've made in with our population and communities. Are there any burning questions before I go to the asks of us? Tim.
Well, yeah, thank you for the report and do welcome and note a lot of progress in some key areas. I think the dental example and the stock take are really good examples. I think I'm more in the place around the recommendations and the asks, and I do think there's an ongoing conversation which we need to be really clear about between places, the provider collaborative itself and other provider collaboratives about the nature of transformation and where that sits. I think it's really important, you mentioned rehabilitation as an example. Local authorities have a really big part of that. General practice is really important in some of the transformation pieces. And we've set up a mechanism, and I think our strategic direction still maintains that where you bring those partners together best is a place. So I think we need to work through together how exactly that works, and I don't think we've cracked it quite yet. And I think we need to be honest about that. Sort of been asked by the Leeds partners who've all managed to leave the room, I note, just before we got to this bit. Just to say that that's definitely a conversation we need to have. We're not yet in the place where we would fully support 2.2. I also think it's reflective of bullet 2.6 in the recommendations. I might misquote, yeah, 2.6.
the ask is to talk to AOs at place. I think it's talk to your partners at place, because these are about partnership discussions, and I think it's really important, general practice, local authorities, voluntary sector, as well as acute and mental health trusts. A lot of the transformation is going to happen in those interfaces. So I welcome a lot of progress, but I think there's still quite a big conversation to be had exactly about how we work with that transformation will type change and resource.
Okay, thank you, Tim. I think you've really sort of put it in a nutshell there. I think that a lot of, we really appreciate all the work that's gone on, but there are some areas that we need to discuss, so we might have to defer some of the asks, but certainly consider them in different spaces before they come back here again. Absolutely. So do people have any questions or areas they want to comment on that haven't already been commented on by Tim? Okay, Lou. I've got Lou, Fatima, James and AC.
So I really welcome the report, and I think there's a really important link to the current planning round, and I know that we'll make that link as appropriate. I know that Becca and I work very closely together, but I just wanted to flag it because it's very current given our first draft plans are going in tomorrow. Thank you.
Great, thank you. Fatima and then AC.
Hello, gents. My name is Fatima. I'm the West Yorkshire Inclusivity Champion. My question is the fact that we've adopted an equity and fairness strategy which has a number of strategic objectives that the whole partnership has signed up to. I just wonder whether there are opportunities to sort of strengthen elements of this proposal with that in mind, and I'm happy to facilitate a conversation. The second one, just building on Tim's point about the transformation in place, is we've just had a conversation about the importance of a warm handover, I've learned today. And there's something about how we can harness that in the context of community services and the different stakeholders. So building on Tim's point, there may be some learning from other systems we might want to look at as well.
Thank you. I'm going to bring Lou in, but if I could just start off on the asks, because I think one of the asks I was going to call Lou in anyway. So yeah. So I think we can endorse the progress made to date and the proposals for the work plan. I think we can do that broadly. Yes. Support the use of the stocktake findings to drive standardization, reduce variation across places. It's good to have a tool that we can use. Yeah. And then agree to begin discussions at pace between place and the accountable officers and YWYCHS. Yeah, which will bring me to the one that I was going to ask, pose to Lou. Confirm expectations around performance assurance and transformation for long waits and community service access standards.
So we've got quite a lot in the current planning definitions that would speak to this, and I think it's about us sitting down and looking at the trajectories and thinking about what's going in from individual organisations, but how that works for the collaborative against this paper, and I think that's something we can really positively do. Thank you.
Thanks, Nadia. Again, thanks, Colin and colleagues, for the update. What I was going to say, Tim has almost covered it, but the last bit that what Tim said. So my question is how does this interface with other collaboratives? So how is this sort of operationalizing in various places? So I just wanted to understand that. And clearly there's more work to be done in that space to better formalize it. But at the end, then Tim mentioned something around how the transformation happens is speak to each providers. But when we do contract out for outcomes, it will be useful to the organization holding the contract. That's who is responsible. So I don't think we have reached that point yet. So if it's not the AO, so I think there is merit in thinking if not the AO, then it's replaced with an IHO equivalent who holds the contract. Else, it's just in the ether and then you don't know who's responsible for what. So it will be useful to see that come through. Thank you.
Yep, thank you. I'll be very quick. I suppose in terms of one of the areas to highlight is, I suppose, around workforce development, given the fact that where workforce is going to sit or potentially sit, I just wondered whether there's a real opportunity there, especially with some of the kind of clinical areas that I come across working across both different collaboratives as well. There are potentially opportunities, and I suppose it's kind of where do we grab that opportunity, and the collaboratives would be one area to consider in terms of that workforce development and for the future, because we're all vying for the same people.
So there's a number of things in there. If I can sort of start it off, and then colleagues can come in on the detail of that. Fully understand ongoing conversation on some of the elements here. We just urge people when going through those conversations to always do the benchmark against what's going to have the biggest impact in terms of current and future patient outcomes and equity as well. That's got to be the guiding star through all of those discussions. You know, I genuinely don't see myself as an advocate here today for the collaborative. I see it as an advocate for our communities, to be honest. Totally agree with the workforce thing. I think there's loads more we can do on that, and colleagues can come in on the detail. And actually, funnily enough, Fatima, something I didn't say, I'd written down that I reckon the stock take hides quite a few health inequalities as well. And certainly we had a board discussion back at the ranch in relation to this. And Victoria, our Chief Nurse, was very, very clear when looking at this, we're going to focus really very heavily through an equity lens as well. But bringing in other colleagues, please.
Just in response to a couple of those points, you ask about how we interface with other collaboratives. So all of our member organisations are part of the place-based partnerships. Our members are also members of the mental health and WIAT as well. I think it's really important that we work out what we do once together, but obviously we recognise that place-based partnerships, we need to develop their own plans around their own populations and take that forward and agree around the workforce development. So we're in conversation about how we can continue to support particularly our AHP clinical population, student-led clinics, some really exciting stuff going on, particularly around dental in that space and what more we could do. So want to continue that conversation.
Just one other thing about the workforce. I certainly know that, say, speech and language therapy, for example, got some very sort of common gaps. And I believe there's some collaborative work that's going on specifically in relation to those issues around workforce. So yeah, definite.
Thank you for that. Therese, do you still need to come in?
I think actually Becky said it. So that I think this collaborative is difficult because community services are so disparate and so different. So I think the bit that you can be really productive in is finding the bit where you can actually add value across. And I think the bit around the coding piece is really important because we do that pretty badly, that sort of standardisation and probably the standardisation around good practice, and then drop things down into place in terms of what we need to do locally for a population. And actually, it's not just place, it's right down into our neighbourhoods. So we're having a conversation this afternoon in Bradford with our neighbourhood strategic group about how we might use that resource across our 7 localities. And we will probably use that resource differently because our localities are all different. But I think that approach is the right one.
Okay, thank you very much. There were 2 other considerations and discussions you asked for, but I think these 2 would be best taken at a later date after we've had some further discussions in the light of our change plans. Rob?
Yeah, so I'm a huge advocate for community services and the impact that they have on people's lives, and much of what goes on in people's homes, focusing on the things that matter to them, it can't get measured in a standard way. So we have to be really careful about how we ensure that we protect, the personalisation of the work that we do, the joined up nature of the work we do, and that we deliver those integrated services in line with our vision. So I'm really keen that we use some of the expertise in the community collaborative to get the right things delivered. And I think what we've agreed today is that, we're endorsing the progress made and the work plan for this year. We think the stock take is where standardisation could take place, and that adds real value. I think we're saying, the guidance and advice of the collaborative on how we want to use the differential resources, not the decision, but, the advice into places about how those neighbourhood models are working and what we're investing in communities is really important. And that we've got a set of expectations in the planning guidance about what's going to be measured and what's got to be delivered. So I think draw a line there and say, right, okay, that's a huge amount of work. that needs to be driven, that we can own and get on with. I sometimes feel we get into a bit of a kind of tussle. I can't remember asking Wyatt, how are you legitimising the work that you do with the other collaboratives? I know I'm caricaturing slightly, but it sometimes sounds a bit like that. I think then if we're saying, I don't yet know what the implications of future tariff models and counting coding reform are on community services. So we're going to have to take that through the organisational change work on the finance work stream. And I think the point that Tim raised about, okay, so if you are members of the places and the places are changing and the provider collaboratives in places are changing, we need to work out how that's going to work. So again, there might be a specific piece of work that we need to do around that through the organisational change programme. Those two things aside, though, I think we've agreed to kind of a big chunk of work that the community collaborative can be getting on with. And we need them to get on with because it's a huge part of the success for the future.
Thank you for that, Rob. One final question from Shaukat. Hope it's IT.
Yeah, I think it's a very, very good report. Just one request and one comment. I think in the context, as it has been mentioned earlier, that one of the shift is in analog to digital, and we have a really big digital tools available there. But I cannot see that how you are leveraging those into this work. Number one. Number two is that the focus on the data part. Remember, we have connecting care record, which is there. We have all the investments there. It's a matter of investing and utilizing those things, right? So I think it would be really great some focus on those things to leveraging into this program, because that will give a visibility from data point of view. But at the same time, there are a lot of, we are talking about collaborative across the community where technology can be an enabler for leveraging the services.
Thank you very much. So thank you all for a really good, thorough discussion here. And thank you for your presentations and your commitment. So we've been able to endorse a few of your asks, but work to be done, and fantastic to be working with you. Okay, thank you. Now you'll be pleased to hear that you can have a break till 4 o'clock. And I mean 4 o'clock. Otherwise you'll still be here at 6. Thank you.